LALWANI, Trab or Trouble, Phaco, Trab or Trouble.
Good afternoon, and thanks AIOS for organizing this state symposium. And your Phaco trap should not become a Phaco trouble. So here is a cataract and glaucoma many times coexist together, and no general consensus on surgical management. And surgeon should decide patient-centric best approach depend upon severity of glaucoma and visual compromise from cataract. So let us take a scenario one. There is a mild glaucoma with very elderly patient with multiple comorbidity, but controlled with only one anti-glaucoma. So you can do Phaco alone in this case, and it will, but negative aspect, it may create significant IOP spikes because of retained cortex or steroid dysfunctional trabecular meshwork, and this IOP spikes sustain for 2 to 4 months. So cataract surgery alone is a bad option in treating uncontrolled primary open-angle glaucoma, but maybe treatment option in acute congestive glaucoma. So let us take second scenario where this is uncontrolled glaucoma despite maximum therapy and SLT with minimal cataract. So we can go for trabeculectomy only, and this reduces the post-op need for IOP lowering therapy, and this may improve the vision and quality of life enough to delay cataract surgery. And cataract surgery can be taken later, two-stage procedure. So where is the combined surgery indication? All this advanced cataract with inadequate control with therapy, adequate control with severe drug-induced side effect, or with advanced glaucomatous optic neuropathy, or uncontrolled glaucoma with urgent need to restore vision, and whenever there is a two surgery are not feasible in the patient's best interest. So let us take Phaco trap. Pros are it is a convenient, reduce the costs, reduce the risk for multiple stresses, anesthesia, and it avoid potential IOP spikes. But negative aspect, it may create more complication, challenging in small pupil, synechies, or zonular stress areas, and induce inflammation in one-side surgery. And after all, it is less effective IOP control in advanced glaucoma. So proper evaluation is the key before doing right Phaco trap, like how many AGMs are patients on, visual acuity, IOP, gonioscopy. You have to all take care, and mistakes can happen from the conjunctival button holing, and videos are not running. So scleral button holing, very anterior chamber entry, trabeculectomy before Phaco you should not do. Posterior sclerostomy, loose scleral suturing. So it is a single side Phaco trap. It saves time, no need to change the position, but induce more inflammation and may spill mitomycin C in an antechamber. This video is also not running. Okay, so single side Phaco trap, you can go from the single port where you do a cataract, then after that trabeculectomy then, but you should resort for the minimal cataract or early cataract. Dual site you can give improved exposure, and it is best in a dual set, narrow interpalpebral aperture, less inflammation, and it may recover rapidly, and it is an enhanced bleb survival. You can see here over the bleb, you can enter from the clear cornea also. This is the dual site also. If you are two surgeon, you can go for temporal cataract, then do from anterior Phaco trap. This is also not working. Okay. So IOP control, both approaches have been shown to be effective in lowering eye intraocular pressure, and two-side surgery may have better post-op control and less need for adjunctive glaucoma medication. So here is you can take out the lessons before the Phaco trap. Maintain antechamber with the use of viscoelastic, use mannitol preoperatively, and it should be clear corneal antechamber entry. Never do trap before Phaco, and never ever antechamber become shallow during procedure. Don't make ostium too posterior, it may induce bleeding, and scleral suture should be tight enough to prevent hypotony, and hypotony is worse than a high IOP. And do a titration before closure, and it should be watertight like you can see over the picture. And thank you all.
ये चालू हो गया।
Okay, time is over. You can see. आपका सर 2 मिनट बचा था. ओके, ठीक है सर. 1 मिनट. So here you can see over the flap you can take clear corneal entry. This is a single site. This is a single site entry, but you should also do as a clear corneal entry, not more anterior, not more posterior. Otherwise, your iris become prolapse and you will be get troubled repeatedly iris prolapse. This is a single site. So it is a very mature cataract. So you can, but you can see over that saline is coming out and chamber is sometimes difficult to maintain in the hard cataract also. You can see the hard cataract here. This is a dual site, per same, no need to change the position. One has to change the position for the temporal clear corner. This is a side port entry. And after this, bus, last. This is the clear corneal entry over the flap. This is the single dual site hard cataract Phaco, and you can after this. Okay.